Whenever you're ready, go ahead.
Hello, my name's Mike Weaver. I'm the Chief of Orthopedic Trauma here at the Brigham and Women's Hospital and Massachusetts General Hospital. Today I'm going to be talking about distal femur fractures, some treatment options, and some surgical strategies to get you through some tricky cases. But first, I'd just like to say hello from Boston. This is Harvard Medical School in the spring, which is a beautiful time to visit if you ever do get the opportunity. These are the hospitals that I work at. This is the Brigham and Women's Hospital, which is right next to the medical school, and then Massachusetts General Hospital, which is across town in downtown Boston. So today I'm going to be talking about distal femur fractures with a focus on different surgical treatments. So we'll talk about lateral lock plating, retrograde nail fixation, and then a couple new techniques that have started to become more popular here in the United States. Nail plate combination fixation, and then dual plating, which I think have some important roles for difficult injuries. I think one of the important things to focus on is the foundation of our AO principles. And so when you're thinking about treating distal femur fractures, I really want you to be thinking about the AO principles, restoration of anatomy, and in particular, that means restoring the alignment of the limb, stable fracture fixation, not necessarily rigid fracture fixation, but stable fracture fixation, preservation of the blood supply to allow the bone to heal, and the early mobilization of both the limb and the patient. Distal femur fractures are a problem. They're a problem for the patient. They're associated with a high risk of morbidity and mortality. They're a high risk of complications. They're a high risk of non-union, and they're often associated with poor functional results. And they're a problem for us as surgeons too. There are lots of options to choose from, and the reduction and the fixation of these injuries can be challenging. And they're all different, right? They come in a wide variety of types and patterns. Here in the United States, there's a lot of people that have knee replacements, and so we see a lot of periprosthetic fractures that can be challenging. They're associated with high energy trauma, and those injuries present and have unique challenges. And then in the geriatric population with poor bone quality, they can be quite difficult to manage. Challenges of treatment include difficult and poor bone quality, bad biology and healing. The non-union rate of distal femur fractures is among the highest of fractures that we routinely fix. They're often difficult in geriatric patients when there's implant obstruction and a frail host. And so when you're caring for these patients, it's really important to optimize the implant choice to maximize the fixation in bad bone. Think about percutaneous treatment options when you can to preserve the biology of the distal femur, and then managing the patient as a whole, particularly with geriatric co-management in frail elderly patients, is really important. Lateral lock plating is kind of the standard treatment, at least in the United States, for some time now for many of these injuries. These plates were developed in the late 1990s to allow for a fixed angle fixation or a cantilever fixation of the distal femur. And that really allows us to treat the distal femur fracture and avoid varus collapse. That was the big problem with these injuries prior to the advent of locked plating. And the other advantage is they allow for percutaneous placement, which we think is a more biologically friendly way of plating the femur. There have been multiple generations of implants since the advent of the initial LIST system, and they've really become the standard for many injuries, although there's a big debate here, at least, between nailers and platers, and there are a lot of people that are now favoring nail fixation, but still a lot of people really believe in lateral lock plating, and it's certainly a great technique to be familiar with. The initial reports of locked plating of the distal femur showed excellent results. This was one of a few early papers. This one was out of Harvard and MGH with one of my colleagues, Dr. Veras, and they showed a very low complication rate. In fact, 18 of 19 fractures healed. But as more studies started to come out, there was an understanding that this type of injury still does have a large non-union risk, and that's related to a lot of different things related to patients, but also how we perform the surgery. We've looked at different factors that influence implant failure and non-union, and found that patient factors including open fractures, obese patients, the presence of infection, and maybe using stainless steel is associated with a higher risk of non-union. When we've looked at things that surgeons can control, things that tend to be associated with non-union are using shorter plates, more proximal screws, and a high total screw density, and then screws crossing the fracture line. So I think this just gets back to our initial AO principles. You know, when you're going to use a plate, it's important to use a longer plate with a lower screw density and no screws crossing the fracture line, because if it is a comminuted fracture, you really want to be bridging this injury. A few tips when you're thinking about plating. It's really important to get the plate as distal as you can to really optimize fixation, particularly in a intra-articular and comminuted fracture. Keep the plate anterolateral. I think a lot of people try to get the plate too posterior, so it's centered on the femur. All of these plates are really designed to sit on the anterolateral aspect of the femur, and that avoids a hockey stick deformity. Here you can see this plate was placed a little bit too posterior, and it medializes the distal femur. While you can still restore alignment, it does lead to a deformity of the femur. And then one thing that I think is particularly useful for a lot of these injuries is the femoral distractor. It really allows you to get length, and particularly if you're taking care of someone that's had their fracture for a few days and they're starting to get short, it's a really powerful tool in obtaining length. And in addition to the femoral distractor, you can add a third pin to control coronal plane alignment, and I'll show you what that looks like in a little bit. So this is an example of a woman, 84-year-old woman who fell down some stairs, and she has this intra-articular comminuted distal femur fracture. So this is something that's pretty common for us here in the States. We have a lot of geriatric patients. And my favorite approach for this is actually a lateral parapatellar approach. This used to be called the Tarpo approach back in the late 90s, but essentially it's just a lateral parapatellar approach. And this gives you great view of the articular surface. It allows you to sublux the patella medially if you need to obtain an anatomic reduction of the joint surface. And then you're looking right at that anterolateral aspect of the condyle, so you can slide up your plate and then apply the proximal screws more percutaneously. And that's what this looks like, right? So the joint surface was exposed, and then I was able to clamp and lag the joint surface. You'll notice that on the notch view, there are two lag screws that are going across the notch of the femur. I try not to do that in young patients, but in elderly patients with poor bone, it's a great way of obtaining better fixation because there's more cortical bone there to grab onto. And this is that same patient a year later, now healed and doing well. So this is a classic strategy, right? Lagging the articular surface to obtain compression and an anatomic reduction of the joint while you're bridging the metaphyseal component and allowing for secondary bone healing. This is another example of using the femoral distractor to help out. This person had a periprosthetic fracture, so knee replacements in place, and it's widely displaced and kind of in a different zip code here. And so using the femoral distractor, placing the pins percutaneously really allows you to control this injury. I typically put one pin in the distal femur and then a second pin in the tibia, and then use the distractor to distract things. One thing to keep in mind is that the distractor, even though it does have some elbows on it, really should be placed in a uniplanar fashion if you can, to avoid a malrotation of the limb. So I place my two pins coplanar, applying gentle traction to the leg to make sure that my rotation is right, and then bring it out to length. This is that same case. So the distractor was applied, and you can see here I over-distracted it, allowed me to reduce the fracture. Again, this is a closed reduction using the distractor. And then once it was reduced, I let off the distractor a little bit to allow compression of the fracture site, and then was able to place a percutaneous plate. You know, and again, predictable healing in a reasonable position here. You know, for some more challenging fractures, you can add an additional pin. So this is a 65-year-old gentleman. He was involved in a motor vehicle collision with this more comminuted and displaced fracture. And so sometimes to control the sagittal alignment, I'll use a third pin. And so that pin is placed percutaneously into the distal femoral segment. That piece tends to want to extend because of the pull of the gastrocnemius muscles, and so you need to counteract that. And so I use that pin to control the distal segment and pull it into position. Now, often I'll hold it temporarily with a lap and a clamp just to hold it. And so this is what that looks like clinically. You can see the distractors on, and that gets the overall length of the distal femur, but that intercalary piece is still extended. And so that pin, you can pull on it and it just keys it back into position. This is another case, obviously, but again, just showing that third pin, which I find incredibly helpful to reduce the sagittal plane of the distal femur. And this is what it's doing, just again, pulling that segment into the correct alignment. This is that same patient in the operating room and then healed. And again, you're treating these as a bridge, using a bridge technique and relative stability. So you want to see this exuberant callus through the metadiaphysis as the fracture heals. Healing is an issue with these. And so there are a few things that you can do to optimize healing. One is the percutaneous placement of implants. It's really important to avoid disrupting the medial periosteum and stripping any periosteum from the bone. We're gardeners, not carpenters, and it's really important that the bone biology is preserved. Avoid any anterior, posterior, and particularly medial dissection whenever you can to preserve that blood supply. It's important, if you're not treating it with a direct reduction and anatomic reduction, don't have any screws cross the fracture line, because all that's going to do is create a high strain environment and increase the risk of non-union. And then again, what we've learned is longer plates with fewer screws is better. You want a low screw density. In general, half of the holes should be empty whenever possible. But not every fracture needs to be bridged. If you have a young patient with good bone and a relatively simple fracture, then things can be put back together. So this is an example of that 59-year-old gentleman that was involved in a motor vehicle collision. Again, this is a little bit more of a more complicated fracture. There's a Hoffa fracture there, which is an important thing not to miss on the lateral side of the femur. He also has a bad plateau fracture. So, you just tackle this in a stepwise manner, obtain an anatomic reduction, lag screw fixation of the articular surface, and then start building proximally. I like to use plates as tools. So it's okay to use a small fragment or mini fragment plate as a buttress plate to help hold things. In this case, it was helping to augment the fixation of that Hoffa fracture. And then once things are fixed, again, moving more proximally, clamping and obtaining an anatomic reduction of the shaft, lag screws perpendicular to the fracture line, and then applying a plate really in a neutralization mode. And so at 2 years, he went on to heal, obviously a little bit of a complicated tibial plateau fracture as well. One thing that comes up particularly here is the importance of mobilizing patients. When there's good fracture fixation, even with plating, it's safe to allow people to do early weight bearing. And so if you're going to keep people off this, I would suggest keeping them non-weight bearing just for 6 weeks and then letting them progress to weight bearing. And that may actually help with the healing. Another good treatment option for distal femur fractures is retrograde nail fixation. This is a great technique because it's done percutaneously, and particularly with newer implant designs, there are more polyaxial screws. You can allow better fixation of more distal fractures. But you do always have to worry about a periprosthetic fracture. Is it something that will be compatible with those implants? So this is an example of a person with an intra-articular distal femur fracture, right? There's a split sagittally through the knee, which is common, and then a more typical metadiaphyseal shaft fracture. And so this was treated through a medial parapatellar approach. That way we can see the articular surface, obtain an anatomic reduction, and then we place 2 lag screws to maintain that reduction. And then, you just want to be careful with those so that you can still place your retrograde nail. Here they were placed both anterior and posterior of where the nail was planned to go, and then the nail goes in to maintain the reduction of the shaft. And again, percutaneous fixation of a fracture, preserves the biology and in particular, metadiaphyseal fractures and diaphyseal fractures of the femur really want a nail. Healing is much more predictable in this area with a nail than a plate. One thing that's come into vogue here is the idea of dual implant fixation. And so people talk about using a combination of nail and plates to fix fractures. They think this provides improved fixation, potentially allowing for earlier weight bearing and maybe less implant failure. And this is a technique that really goes back to the past. You know, Jeff Mast, master surgeon here in the 1980s, popularized the idea of intramedullary plating in addition to a lateral plate to improve fracture fixation. And I think nail plate fixation is really just a modification of this. The initial publications of this came out of Vanderbilt. Bill Obremski and his team showed that this is a very effective tool in the treatment of femoral non-unions. And so if you do have a distal femoral non-union, I do think this is a fantastic treatment for that. And there are some others that have been using it for primary fractures. All of the reports of these are relatively small, but the results are good. This is an example of what that looks like. So an 83-year-old woman who fell on her knee and has this periprosthetic fracture. So typically when I'm doing a nail plate fixation, I want to put the nail in first because you want to maintain the overall alignment and then build the plate around it. One or two of the implants needs to be a lot longer or shorter than the other. Often I'll go longer with the nail. In this case, we went shorter with the nail because there was a hip prosthesis up above. And then once the nail's in place, you can put the plate on. There are some newer implant designs that allow for buried locking screws of the nail, which are particularly helpful. Biomechanical studies show you do not need to put the screws through both the nail and the plate. There's no advantage to that. But certainly with two implants, we're a lot more confident allowing early weight bearing. Here's another example of that. 75-year-old fell down injuring her right knee. And again, this time a long nail and then a shorter plate. Again, main thing here is restoring the coronal plane alignment. If you're going to get one thing right in the distal femur, it's getting the coronal plane alignment right. And again, predictable healing. I do think some of these patients do go on to an implant-dependent union, but certainly it's a very effective tool. And then I'll finish up with a technique that's starting to gain some popularity here too, which is the idea of using a medial plate to augment fixation of a lateral plate. Definitely it confers more stability biomechanically, but there's definitely a biologic cost to it. I find these particular fracture patterns when you've got this large medial oblique spike are perfectly suited for this technique because you can use a small fragment plate on the medial side to buttress that in and then squeeze the condyles to restore the anatomy of the distal femur. So in summary, there are a lot of different options for distal femur fractures: lateral lock plating, retrograde nail fixation, and nail plate combination fixation. Whenever possible, think about percutaneous fixation options. Try to be biologically friendly, and then allow early weight bearing of the patient and mobilization of the limb. And above all else, you've got to restore the coronal plane alignment of the leg. That's the number one thing. And I would just suggest that the femoral distractor in particular is a very useful tool in this situation. It really helps get length and helps you restore alignment, particularly in fractures that have been sitting around for more than a day or two when the soft tissues can be contracted or there may be some early callus that you have to deal with. And as always, follow your AO principles, right? The main thing is that you restore the anatomy of the limb, you obtain and maintain stable fracture fixation, preserve the blood supply to the bone fragments, and allow for early mobilization of the limb and patient. Thank you.